Hi everyone, my name is Charles Bond, and I am owner of Ceramics West Dental Lab here in Portland, Oregon. And our lab is focused on full arch cases. So we do guided surgery, temporization, and final prosthetics only on full arch cases. I also have a training company called Alliance Training. The website is wearealliancetraining.com, and we cover more in-depth topics like I'm going to discuss today, which is the digital conversion utilizing the new Optisplint RADIOPAQUE healing caps. So for full arch cases, we really have two main issues or bottlenecks in terms of records and predictability. Number one, primarily for mandibular cases, is how can we use registration points that don't require bone screws or keeping teeth. So, especially for mandibular cases, it can be challenging to have bone screws or even arch tracers far enough back in the retromolar pad. And also, if you try to get one down in the symphysis, it has to be below the bone reduction level. And so, while you might be able to capture those in your pre-op scan, usually in the post-op scan with blood and sutures, it can be hard to capture those registration points, number one. Number two, we also need to find a way to make our occlusion more predictable. More specifically, how can we maintain and find centric relation and keep that all the way through our temporary to the final prosthesis? And so the healing cap, the radiopaque healing cap from Optisplint solves all those issues. So here's the case. Um, this is Patricia, and one of the things you want to do in terms of records is that you want your CT scan to be as big a field of view as possible. And so in this case here, even though this is going to be a maxillary case, you can see we have the condyle here. So if this was a mandibular case or if this was a double arch case, being able to see and visualize the mandible seated, having the condyle seated in the fossa is super important because that tells us that this patient is in centric relation and that we can use this segmentation as landmarks for our post-op records. But again, in this case, this happens to be a maxillary case. And so what we do is we segment out the maxilla, the region of interest. In this case, it is the maxilla. And then we merge in our scans. So we've got our pre-op scan for the maxilla mandible, and it's in the correct bite, which is imported from Trios. And we can double check the position and that bite to make sure that it corresponds with our CT scan, which we've already determined is in central relation. This case can be done guided or non-guided. This case happened to be guided. So the process is we place the guides, we extract the teeth, do the bone reduction, place the implants, place the multi-unit abutments, put the Optisplint scan bodies luted together with the flap open so that we can visualize and make sure that everything is seated properly. And then we take that off, put on the radiopaque scan caps, and then the clinician will suture around those scan caps. And then we take a post-op CT scan. So just to quickly show you what that stack of scans looks like, here is the same case. And this is in Zircon, which is basically exocad. And so what you're looking at right now is our pre-op CT scan with our pre-op intraoral scan merged to it, and that comes directly from Co-Diagnostics. And then we've got our lower arch also from Co-Diagnostics. And again, we've already verified that this is in central relation, so we're going to maintain that throughout the process. And so what we do is that after surgery, you take a post-op CT scan. And in this case, it's the upper arch. What you want to do is you want to make sure that the healing caps are not touching the lower dentition. So you can use a bite block or cotton rolls just to keep some space between those healing caps and the lower dentition. If this was a double arch case, same thing. You don't want those healing caps touching each other. You want a little bit of space. And so this is our post-operative CT. And so these are the radiopaque scan caps from Optisplint. So you can see they show up quite well. And what we do is we segment this within co-diagnostics. We have more detailed videos and one-on-one training in Alliance Training. And what we do is we merge using all of these registration points. So if you just think about if you had 1 to 2 markers, let's say in the palette, whether it's bone screws or arch tracers, you only have a certain amount of registration points. In this case, if you see, I'm going to overlay the two. I have literally an unlimited amount of registration points. I've got the entire hard tissue on the maxilla to merge these two scans together. So what we get is we get very accurate merging, which manifests itself also in a more predictable occlusion. So we merge our post-op CT scan to a pre-op CT scan. And so at that point, I'm pretty much done with my pre-op. I don't really need it, so I'm gonna turn that off. And here is my antagonist, which also is from our trio scan, but verified within co-diagnostics. And what we do is we use our post-op CT scan and we merge it to our post-op trio scan. So once everything's sutured, we use our intraoral scanner to capture the tissue and scan the healing caps, which looks like this, and we merge it to our post-op CT scan. So now we have a very accurate tissue morphology. This step is technically optional. The intraoral scan is technically optional. We don't really need it. I can more or less guess where the tissue is going to be and more or less get a pretty good tissue contact, but having the intraoral scan, I feel like just makes it a lot more predictable. And so we don't end up with areas that are under contoured or over contoured. And so this is our post-op intraoral scan. And the last step is to merge our Optisplint. And so what we do is we don't even bother scanning this in the mouth, although you can. We scan this outside the mouth on the scan plate with either our intraoral scanner or their lab scanner. And so it's a lot easier. You get a much more accurate scan. And then what we do is the healing caps have the exact same geometry as the scan bodies on the Optisplint scan jig. And so we merge those two things together. So now we've got pretty much everything we need. We have our implant positions, we have our soft tissue morphology, we have our antagonist, and in this case, we did wax this up ahead of time. So here is our wax up. This is an FP1 case that we ended up doing. So we waxed up the case, and then all we did was merge in our implant positions from our Optisplint. So we used the Optisplint. We used, in this case, we used tie bases. This was a Straumann case. So we used Straumann SRA Vario bases. And then here is our finished temporary. Just like that. So that's our FP1 temporary. And so what we did was we had a pre-op scan, centric relation, as large a field of view as possible. Our post-op records are a tissue scan with the healing caps, a post-op CT scan with enough clearance between the healing caps and the lower dentition, and then also your Optisplint, which we prefer to scan outside the mouth with a intraoral scanner or our lab scanner. And again, for a mandibular case, you may not see that much of a difference if you compare it to your normal workflow, but for lower arch cases, for double arch cases, being able to use segmentation in your CT scan, and also not being able to worry about putting in bone screws, scanning them, and then only having a few registration points. What we find is with this method, it's less work for the clinician. You have much more accurate registration of your scans, and you have a more accurate bite because we're maintaining this case in centric relation. So hope that was helpful. Please visit us at wearealliancetraining.com with more questions, and see you next time.